Welcome to Healthcare UK, your trusted source for clear, evidence-based health insights from the front line of UK healthcare. I'm Leda, a registered nurse. If you value credible health information, make sure you subscribe and hit the notification bell so you never miss an update.
Question 1. A 72-year-old man presents with a 2-hour history of severe, crushing central chest pain radiating to his jaw. His ECG shows ST segment elevation in the anterior leads. What is the most appropriate immediate management? A. Administer high-flow oxygen via a non-rebreather mask. B. Give 300 milligrams of aspirin to chew and arrange immediate primary percutaneous coronary intervention, PPCI. C. Start a glyceryl trinitrate, GTN, infusion for pain relief. D. Administer intravenous morphine and arrange an urgent cardiology ward review. Answer: B. Give 300 milligrams of aspirin to chew and arrange immediate primary percutaneous coronary intervention, PPCI. Explanation: this is a classic presentation of an ST elevation myocardial infarction, STEMI. The goal is to reperfuse the occluded coronary artery as quickly as possible. PPCI is the preferred reperfusion strategy where available. Chewed aspirin, 300 milligrams, is a critical antiplatelet therapy given immediately. Routine high-flow oxygen, A, is no longer recommended unless the patient is hypoxic, as it can cause vasoconstriction, while IV morphine, D, is used for pain relief and GTN, C, for symptom relief. They are adjuncts and do not replace the urgent need for reperfusion. Question 2. A 28-year-old woman presents with palpitations, tremor, and heat intolerance. On examination, she has a tremor and a small, non-tender goiter. Thyroid function tests show T4 45 picomole per litre, 10 to 22, T3 12 picomole per litre, 3.5 to 6.5, TSH 0.01 milliunits per litre, 0.3 to 4.5. What is the most likely diagnosis? A. Graves' disease. B. Subacute thyroiditis. C. Toxic multinodular goiter. D. Thyroid-stimulating hormone, TSH, secreting pituitary adenoma. The answer is A. Graves' disease. Explanation: the biochemistry confirms thyrotoxicosis, elevated T4, T3, suppressed TSH. In a young woman with a diffuse, non-tender goiter and symptoms, Graves' disease, an autoimmune condition, is the most common cause. Subacute thyroiditis, B, is typically painful. Toxic multinodular goiter, C, is more common in older patients, and the gland would be nodular. A TSH-secreting adenoma, D, would show high, not suppressed TSH levels. Question 3. A 65-year-old man with a history of COPD is admitted with a 3-day history of increased shortness of breath and purulent sputum. His observations are HR 105, BP 135/85, RR 26, SpO2 88% on room air. What is the most appropriate initial oxygen therapy? A. High-flow oxygen via a non-rebreathe mask. B. No oxygen is required at this time. C. Titrated oxygen via a Venturi mask to achieve a target SpO2 of 88 to 92%. D. Continuous positive airway pressure, CPAP. Answer: C. Titrated oxygen via a Venturi mask to achieve a target SpO2 of 88 to 92%. Explanation. In patients with COPD and potential type 2 respiratory failure, uncontrolled high-flow oxygen can abolish their hypoxic drive, leading to CO2 retention and respiratory acidosis. The BTS guidelines recommend titrating oxygen to a target saturation range 88 to 92% in most at-risk COPD patients to correct hypoxia without causing significant hypercapnia. With an SpO2 of 88%, oxygen is definitely indicated, so B is incorrect. CPAP, D, is used for more severe respiratory failure, not as first-line oxygen therapy.
Question 4. A 4-year-old boy is brought to A&E with a 12-hour history of fever, lethargy, and a non-blanching rash on his trunk and limbs. He is drowsy. What is the most urgent initial action? A. Perform a lumbar puncture to confirm the diagnosis. B. Give paracetamol for the fever. C. Administer intravenous antibiotics immediately. D. Order a full blood count and clotting screen. Answer. C. Administer intravenous antibiotics immediately. This is a classic presentation of suspected meningococcal septicemia, which is a time-critical medical emergency. The NICE guideline for meningitis and septicemia states that intravenous antibiotics, for example, ceftriaxone, must be given immediately within 1 hour of arrival if suspected. A lumbar puncture, A, is contraindicated in this unstable, drowsy child and would delay treatment. Investigations, D, should be done concurrently but must not delay antibiotics. Symptom control, B, is a low priority in this context.
Question 5. A 55-year-old woman with a history of type 2 diabetes and hypertension is found to have a potassium level of 6.1 millimoles per litre on routine bloods. She is asymptomatic and her ECG is normal. What is the most appropriate first-line management? A. Intravenous calcium gluconate. B. Intravenous insulin and dextrose. C. Sodium polystyrene sulfonate, Resonium. D. Review her medication list and repeat the blood test. Answer. D. Review her medication list and repeat the blood test. Explanation. This is mild asymptomatic hyperkalemia with no ECG changes. The first step is to exclude a spurious result, for example, hemolyze sample, and identify the cause, most commonly medications like ACE inhibitors, for example, ramipril, ARBs, or spironolactone. Repeating the test is crucial. Aggressive treatments, A, B, and C, are reserved for severe hyperkalemia, greater than 6.5 millimoles per litre, or when ECG changes are present.
Question 6. On a post-take ward round, you review a patient who is 36 hours post-emergency laparotomy. Their observations show a temperature of 38.5 degrees Celsius. What is the most common cause of fever at this time? A. Hospital-acquired pneumonia. B. Surgical site infection. C. Atelectasis. D. Urinary tract infection. Answer. C. Atelectasis. The 4 W's mnemonic for postoperative fever is helpful. Wind, atelectasis, equals day 1 to 2. Water, UTI, equals day 3 to 5. Wound, SSI, equals day 5 to 7. Walking, DVTPE, equals day 7 plus. At 36 hours, day 1 to 2, the most common cause is atelectasis, or collapse of small airways, due to poor lung expansion post-surgery under general anesthetic.
Question 7. A 70-year-old man is admitted with a fall. A CT head shows a chronic subdural hematoma. His regular medication list includes apixaban, 5 mg BD for atrial fibrillation. The neurosurgical team plans to operate. In preparation for surgery, What is the most appropriate action regarding his anticoagulation? A. Stop apixaban and proceed to surgery. B. Stop apixaban and administer vitamin K. C. Stop apixaban and administer prothrombin complex concentrate, PCC. D. Continue apixaban as the risk of stroke is high. Answer: C. Stop apixaban and administer prothrombin complex concentrate, PCC. Explanation: Apixaban is a direct oral anticoagulant, DOAC. For urgent surgery, especially with a high bleeding risk like neurosurgery, reversal is required. PCC is the recommended agent for rapid reversal of DOACs. Simply stopping it, A, is insufficient due to its approximately 12-hour half-life. Vitamin K, B, is used for warfarin reversal, not DOACs. Continuing it, D, would lead to a catastrophic bleed during surgery.
Question 8. A 45-year-old woman is diagnosed with community-acquired pneumonia, CURB-65 score 1. She has no drug allergies. What is the most appropriate first-line antibiotic regimen according to UK guidelines? A. Intravenous coamoxiclav. B. Oral amoxicillin and oral clarithromycin. C. Oral amoxicillin alone. D. Oral doxycycline. Answer: C. Oral amoxicillin alone. Explanation: For low-severity community-acquired pneumonia, CURB-65 0-1, the NICE guideline recommends oral amoxicillin as first-line monotherapy. Dual therapy with a macrolide, B, is reserved for moderate-severity pneumonia, CURB-65 2+, or if atypical pathogens are suspected. Coamoxiclav, A, is used for higher severity or if aspiration is suspected. Doxycycline, D, is an alternative for penicillin-allergic patients.
Question 9. You are reviewing a patient with severe peripheral arterial disease. Which combination of findings on examination is most characteristic? A. Pulseless, pale, painful, perishingly cold, paresthesia. B. Pulseless, pigmented, painful, pitting edema. C. Bounding pulse, pink, painful, peau d'orange. D. Pulseless, pink, painless, pitting edema. The answer is A. Pulseless, pale, painful, perishingly cold, paresthesia. This is the classic presentation of the 6 Ps of acute limb ischemia, which is a surgical emergency. While it describes acute ischemia, the features, pulselessness, pallor, pain, coldness, and neurological dysfunction like paresthesia, are also hallmarks of severe chronic disease. Option B describes venous disease, C describes cellulitis or inflammation, and D is inconsistent.
Question 10. A 25-year-old primigravida woman at 32 weeks gestation presents with painless vaginal bleeding. She is hemodynamically stable and cardiotocography (CTG) is reassuring. What is the most likely diagnosis and the most appropriate initial investigation? A. Placental abruption, bedside clotting studies. B. Vasa previa, speculum examination. C. Placenta previa, transabdominal ultrasound scan. D. Cervical ectropion, cervical smear. Answer C. Placenta previa, transabdominal ultrasound scan. Explanation: Painless vaginal bleeding in the 3rd trimester is the hallmark of placenta previa. The initial investigation of choice is an ultrasound scan to locate the placenta. A digital vaginal examination is contraindicated as it can provoke massive hemorrhage.
Placental abruption, A, is typically associated with painful, dark bleeding and a tense uterus. Vasa previa, B, is rare and often presents with bleeding at rupture of membranes.
Part 2. Situational Judgment Test, SJT. For the following questions, rank the responses in order of appropriateness. Format: 1 equals most appropriate, 2 equals appropriate but not ideal, 3 equals inappropriate but not worst, 4 equals least appropriate. Question 11. You are an F1 on a busy ward. A senior staff nurse approaches you and says, "You prescribed a drug for bed 5 that they are allergic to. Luckily, I spotted it before giving it. The patient is fine." How do you respond? A. Thank you so much for catching that. I will review the drug chart and patient notes immediately and speak to the patient to apologize. B. Please don't mention this to anyone. I will correct it now and be more careful. C. Are you sure? I was very careful when I wrote the chart. Can you double check? D. These things happen. The patient is fine, so let's just move on and correct it. Answer 1. A. 2. D. 3. C. 4. B. Explanation. A. 1. Is the gold standard. It shows gratitude, takes immediate responsibility, and plans for open disclosure with the patient. D. 2. Is suboptimal. As it's dismissive, these things happen, but at least acknowledges the need to correct the error. C. 3. Is inappropriate, as it deflects blame onto the nurse. B. 4. Is the least appropriate and unprofessional, as it attempts to cover up the error, which is a serious breach of duty of candor.
Question 12. You are in clinic with a consultant. A patient becomes upset and angry when given a cancer diagnosis. The consultant remains calm, but the patient starts shouting personal insults at them. What is the best course of action? A. Immediately call hospital security to remove the patient. B. Firmly tell the patient that their behavior is unacceptable and they must stop. C. Sit quietly and allow the consultant to lead the situation. D. Try to lighten the mood by making a joke to diffuse the tension. Answer 1C, 2B, 3A, 4D. Explanation. C, 1, is best. As a junior, your role is to support the senior who is leading the consultation. They are handling it calmly, and your intervention could escalate things. B, 2, is a potential escalation if the consultant fails to de-escalate, but it's not your first move. A, 3, is an overreaction at this stage. D is highly inappropriate and disrespectful given the context of a cancer diagnosis.
Question 13. You were on call and bleeped by a nurse on a ward you don't know. She asked you to prescribe IV fluids for a patient. You were in the middle of managing a sick patient in A&E. What do? A. Ask the nurse to read you the patient's recent observations and blood results over the phone so you can prescribe without seeing the patient. B. Tell the nurse you are busy with an emergency and will come as soon as you are able. C. Ignore the bleep until you have finished in A&E. D. Suggest that the nurse contact the on-call registrar for this task instead. Answer 1, B, 2, D, 3, A, 4, C. Explanation. B, 1, is the most appropriate. It communicates professionally, manages expectations, and acknowledges the request. D, 2, is a good alternative if the task is urgent and you are genuinely detained. It ensures patients' safety by seeking an alternative solution. A. 3. Is dangerous as you are prescribing for a patient you haven't assessed. C. 4. Is unprofessional and neglectful.
Question 14. An F1 colleague confides in you that they are feeling overwhelmed and have made several minor prescribing errors in the last week, though all were caught by nurses. What should you do? A. Advise them to speak to their clinical supervisor or the guardian of safe working. B. Tell them not to worry, as everyone makes mistakes. C. Offer to take on some of their jobs to reduce their burden. D. Report them to the consultant, as patient safety is at risk. Answer: 1. A. 2. C. 3. B. 4. D. Explanation. A. 1 is the best response. It encourages them to seek formal support from the appropriate person, which is the most sustainable and safe solution. C. 2 is a supportive and kind action, but it doesn't address the root cause. B. 3 is dismissive of the serious issue of repeated errors. D. 4 is a last resort if they refuse to seek help themselves. Jumping straight to reporting a colleague who has confided in you would breach trust and should not be the first step.
Question 15. You are asked by your registrar to consent a patient for a procedure. You have seen the procedure performed once, but are not fully confident in explaining all the risks and benefits. What do you do? A. Consent the patient anyway, as the registrar is busy and you don't want to let them down. B. Tell the registrar you are not comfortable and refuse to do it. C. Ask the registrar to talk you through the key points and then attempt to consent the patient under their supervision. D. Defer consenting and suggest the patient looks up the procedure online. Answer: 1. C. 2. B. 3. A. 4. D. Explanation. C. 1 is ideal. It demonstrates professionalism, a commitment to patient safety, and a willingness to learn. It turns the situation into a training opportunity. B. 2 is better than doing it incorrectly, but it is a passive refusal and misses a chance to develop your skills. A. 3 is unsafe and unethical, as valid consent requires adequate knowledge. D. 4 is an abrogation of your duty and is completely inappropriate.
Question 16. You notice that a consultant consistently submits discharge summaries several days after patients leave the hospital, leading to delays for GPs. What is the best first step? A. Mention it openly in the next departmental meeting to shame them into action. B. Speak to the consultant privately and express your concern about the impact on patient care. C. Report the consultant to the clinical director. D. Nothing. They are a consultant and it is not your place to comment. Answer: 1. B. 2. C. 3. A. 4. D. Explanation. B. 1 is the most professional first step. It addresses the issue directly, respectfully, and privately, giving the consultant a chance to correct their behavior. C. 2 is the appropriate escalation if the private conversation fails. A. 3 is unprofessional and confrontational, likely to create animosity. D is wrong. Patient care is being compromised, and all staff have a responsibility to speak up about safety concerns.
Question 17.
A patient with capacity is refusing a blood test that you believe is essential for their management. How should you proceed? A. Acknowledge their decision, explain the potential consequences of not having the test clearly, and document the refusal. B. Coerce the patient by emphasizing only the worst-case scenario to persuade them. C. Perform the blood test anyway, as it is in their best interest. D. Tell the patient they are being unreasonable and that you will need to document their non-compliance. Answer: 1. A. 2. B. 3. D. 4. C. Explanation. A. 1 is correct. It acknowledges patient autonomy, ensures they are making an informed decision, and provides a clear legal and clinical record. B. 2 is a form of coercion and is unethical. D. 3 is confrontational and uses judgmental language, non-compliance. C. 4 is battery and a serious legal and ethical violation.
Question 18. You are feeling unwell with a high fever and diarrhea at the start of your shift. What should you do? A. Take some paracetamol and start your shift, as the team will be short-staffed. B. Contact your clinical supervisor or the rota coordinator as soon as possible to report your sickness. C. Ask a colleague to cover your jobs informally without telling anyone in charge. D. Go to the hospital's A&E department to be seen. Answer: 1. B. 2. D. 3. A. 4. C. Explanation. B. 1 is the correct and professional procedure. It ensures the team is formally notified and can arrange safe cover. D. 2 may be necessary if you require urgent medical attention, but your first duty is to call in sick. A. 3 is unsafe for both you, risking your health, and your patients, risking transmission of infection and impaired performance. C. 4 is unprofessional and leads to an unmanaged, unsafe situation.
Question 19. During a cardiac arrest call, you are the first doctor to arrive. The nurse in charge asks you to lead the resuscitation. You are an F1 and have never led an arrest before. What do you do? A. Take charge immediately to provide leadership, even if you are unsure. B. Delegate the leadership role to the most senior nurse present. C. State clearly, I am an F1. Can someone more experienced take the lead while starting basic tasks like chest compressions? D. Focus on putting in a cannula and stay out of the way of the leadership decision. Answer: 1. C. 2. B. 3. A. 4. D. Explanation. C. 1 is the safest response. It is honest about your limitations, calls for the required help, and remains useful by contributing to the team effort. B. 2 is less ideal, as medical leadership is preferred but is safer than an inexperienced leader. A. 3 is dangerous, as poor leadership can compromise the entire resuscitation. D. 4 is passive and fails to communicate the critical lack of leadership.
Question 20. You are asked to review a patient who is confused. On arrival, you find a student nurse trying to restrain the patient to prevent them from pulling out their nasogastric tube. What is your immediate priority? A. Help the student nurse to restrain the patient more effectively. B. Administer a sedative medication to calm the patient. C. Assess the patient's capacity and the cause of their confusion, and de-escalate the situation verbally. D. Bleep the registrar and wait for them to arrive. Answer: 1C, 2B, 3A, 4 D. Explanation. C. 1 is correct. Restraint should be a last resort. The immediate priority is a medical and cognitive assessment to find a reversible cause, example, infection, pain, and to attempt de-escalation. B. 2 is a chemical restraint that should only be considered after assessment and if verbal methods fail. A. 3 is physical restraint and is not the first-line approach. D. 4 abdicates your responsibility as the first responding doctor.
I hope that deep dive into CBT questions was helpful. If it was, a like would be amazing.